Great. Sally, I will now turn things over to you to get us started.
Great. Thank you, Becky, and welcome everyone to the Small Hospital Improvement Program. And today we're having a State Coordinator Technical Assistance webinar. And just a reminder, the National Rural Health Resource Center is your technical assistance provider for the SHIP program, and that's part of our Rural Health Cooperative Agreement, where we also provide services and education for technical assistance in the Medicare Rural Hospital Flexibility Grant Program and the Small Rural Hospital Transitions Program. And today we'll be having an update from Bridget Weir, Project Coordinator for the SHIP program at the Federal Office of Rural Health Policy. We have a SHIP State Spotlight from Alaska, and Shelly Smith will be presenting on that. And then we'll spend some time going through some results from the fiscal year 17 SHIP NCC applications. There were some questions added about suggested activities and improvements in the SHIP program. So we'll share the responses from that, but also dig a little deeper into some of those questions and responses with some polling that we'll do live. And finally close out with next steps in TA. So I will first turn it over to Bridget Weir from the Federal Office of Rural Health Policy. Bridget?
Thanks, Sally. Appreciate that. Hi, everyone. I just wanted to say that Janina and I have spoken to just about everyone over the last month or so, and we've enjoyed talking with you and hearing from you and being able to tell you how good a job we thought you did with your SHIP applications. And with that, I'll just get into a few of the stats for the update. So by now, most of the NOAs are out or should be out. If you haven't received yours, please contact your grants management specialist. And I heard BJ, one of them, on the line. So if you have any questions, maybe, and if we have time, maybe it's something he might be able to answer for you. Not about your specific NOA, of course, but if you have general questions. Also, if you haven't done so, please check your NOA for outstanding conditions. Most of those that came from our office would give you about 30 to 45 days to complete. So if you've not completed or submitted a revision or a response to your condition, I would urge you to do so at this point. It could affect or impact your award next year if you don't do that. So this year for SHIP, we had a total of 46 awards with about 1,600 hospitals. And as you all know, we were able to give out about $9,000 per hospital. We had a number of awards that went out with a condition for revised budget, which caused a little confusion. What was really being asked for was a submission of your 424A. So your 424 has to come in with each of your applications. So that will be made clear in the next SHIP application, that your 424A is always to be submitted. So there was some confusion with that, so I just wanted to make sure I clarified that. And I think those are the major updates that I have for the SHIP application. As I said, we enjoyed speaking with you, and at that time we were also able to talk with you a little bit more about some of your recommendations for improving the SHIP program. And so we appreciated your time and your input, both that which you wrote in your NCC and that which you shared with us during our calls. And so with that, I want to leave a lot of time for Shelly to talk about Alaska and time for questions as well. But if there are any questions, feel free to let me know, and I'll be happy to talk with you further about it.
Thank you, Bridget. for that update. Well, I'll now turn it over to Shelly Smith, and Shelly's the SHIP grant coordinator for the state of Alaska, and she is also the Flex coordinator in Alaska and been in that role since 2013. And their program is based at the State Department of Health. And Shelly is sharing with us creating a group SHIP experience, as we know many of you are looking at ways to maybe streamline the administration of SHIP and look at more group or consortium activities. And Alaska was one that came in this year is trying that. So I will turn over to you, Shelly.
Okay, I think that I have *2 on my line, so hopefully you can hear me.
We can hear you. Yes, we can. Thanks.
Okay. All right, let's see if we can down arrow and change the slide. Nope, that didn't work.
Okay, try the arrows at the bottom of the screen.
At
They're
the
horizontal arrows. Or I can forward it for you.
I think.
Yeah.
I think we just got it. Okay. All right. Okay. Well, Alaska is a state, and the SHIP program was a program that we had talked about doing some sort of group experience. And the hospitals have said for a few years that they wouldn't mind pooling their money and doing a group settlement, group type of program. But one thing about Alaska is we're big and we're rural and we're remote. As you can see from the map, we're almost, we cover a great deal of the United States. And if you see the red lines on the state of Alaska there, those are the roads that we have in Alaska. So we basically only have 4 roads, and most of our communities are not connected by a road. We have a number of small hospitals that participate in the SHIP program, and those hospitals really are quite diverse. We have a total of 14 critical access hospitals. 5 of those are independent. 4 of those critical access hospitals are a part of a larger system, and 5 are tribal. While our 3 small hospitals that usually participate in the SHIP program, 2 of those are independent and 1 is tribal. And so not only do we have a diverse background, but then I looked at, well, what is available within the hospitals themselves, their infrastructure that they have. And when I looked at that, I found that they all had different types of computer systems. So how they accessed information and how they processed information was quite different in each of the, in many of the hospitals. That makes it kind of hard to, put together a group activity when everybody's so far apart, everybody's so different. But I went ahead and I asked, and as I said, all the hospitals were interested. They said, yes, we'd love to pool our SHIP funds. We'd love to do a group project. And so I asked for input of what they would like to do. And that was kind of the death knell for how the project might move forward. So I kind of looked at that as trying to pull together a group activity, and I didn't think it met with very much success. So what happened in the meantime was the NOA came out, and then another NOA came out that I read the first NOA, and the second NOA I didn't read. So this is kind of a lesson that I learned, is that you should read every NOA that comes out, because as you can see from this, there are dates of issue, and then they will have different amounts or different instructions on them in the various areas. So my lesson was look at every NOA that comes out and read carefully all of the parts of the NOA so that you understand what's happening. So I worked off the first NOA, did my budget, sent out hospitals their checks, and then somebody brought to my attention the second NOA with additional funding. So when things don't go as planned, I had to come up with some sort of different plan, and a GPS system would have helped if it was capable of making those types of decisions, but it isn't. So what can I do to make this error work in our favor? And so I wanted to look at, well, the hospitals that are there, and what are the highest levels of commonality that we have, and what were the hospitals, what were the things they were interested in on their SHIP purchasing menus. And so out of 14 of the 16 small Alaska hospitals, most of them are critical access hospitals. Because of that, most of them are participating in both the SHIP and the Flex Grant programs. And the SHIP and the Flex Grant programs are complementary. Because so many of the hospitals wanted to look at quality improvement, reporting and activities, and because a lot of the hospitals are reporting the same measures through the programs, that seemed like that would be the most appropriate type of group action to put together. And rather than try and pull ideas from them and try and put an activity together, I decided that I would do a push type of outreach, and we would put together a group based on that common interest on quality improvement, and also we were looking at financial and operational efficiency. But most of the emphasis was on quality improvement by far. So that looked like the most promising way for us to go forward. And when I looked at the problems with Alaska's quality measures, I looked to the Flex program, and I could see that there's a number of times when quality measures were not being reported. So this looked like a good area for us to explore. And as you can see here, there is a lot of no responses from our Alaskan hospitals. So the outpatient measures were the measures in the different quality domains of the Flex program that stood out as having the most problems. So that was my decision, was to focus on, well, those measures that are giving us the most problems, let's bring in some technical expertise and let's push it out to the hospitals to help support them and overcome those barriers to reporting. So I decided that we would work as one. You know, they won't be asked whether they want to participate or not. They already indicated to me they wanted to participate in quality improvement as they indicated on their SHIP menus. So we identified the most problematic as the outpatient measures by looking at the Flex program and also looking at the SHIP menus. And so we looked at, well, how can we do this without duplicating the Flex program? And in the Flex program, we had a lot of support that were going to the hospitals to be able to work with the quality net reporting. And the hospitals were getting a lot of technical support in how to get into quality net, how to register for quality net, how to make those reports, how to pull reports from quality net, and how to understand when their measures, their data was still excluded from the data set. So what we wanted to do was look at definitions and really focus on the measurements themselves. We wanted the hospitals to understand what the clinical implications are of this reporting, what these measures actually mean. And as I said, we don't want to do duplication of what's going on in the FLEX program. We want to complement what's going on in the FLEX program. So what we did is we brought in the Quality Improvement Organization, and they were to focus on reaching out to the hospitals one by one, talking with the hospitals as to, these are all the measures that you need to be reporting on. This is what these measures mean. This is how you pull the measures, looking at the data that you have in your medical records. And there were 4 webinars that were given to the hospitals with great attendance, and then there was also one-on-one contacts with the hospitals to follow up and make sure that they really did understand what these measures meant and how to actually and accurately measure them. We expected that because of this activity, we would see better consistency in reporting. We would see more accurate reporting because they understood the measures better. We would be able to help the hospitals remove any barriers that they had to reporting, and that the hospitals would feel that they really were supported out there in their reporting efforts, and that we were making extra effort to make sure we didn't leave them on their own, that they had the support and they could call us at any time and get that extra support. It's a little bit early yet to know what outcomes that we're going to see. I know for the some of the outpatient measures, such as the IMM2, we did increase the reporting rate by 133% in this last quarter. So that's one measure that I can look at and say that we've done, but we're still waiting for more measures to come in. So with that, I'll ask, is there any questions about the program?
Okay, star 2 to unmute, or you may put questions in the chat box as well. I see one coming in. And the question is, are all of Alaska's SHIP hospitals also critical access hospitals, Shelly?
The majority of them are, but there are a few that are not critical access hospitals. We had 3, I think it was, that were not critical access hospitals in the program.
Another question coming in. And this was a nice example how you just try to complement the other grant programs and working with various subject matter experts, such as the QIN and the state, to help in the specific area of quality. And Rebecca from Oregon states, did all of the hospitals easily agree to participating in the pooled option? No pushback from anyone.
Well, in this case, what I didn't do was give them the option to not participate as far as the pooled money was going to go. It would have taken more effort and more time to reissue checks to the hospitals than what we had available in the rest of the year. So what it was is it wasn't that you're going to be doing more work. What it was is, I'm just going to push out this technical assistance to you. I'm going to push out this one-on-one contact to help you with these outpatient reporting measures. And let's see if we can improve in the quality area. The hospitals were very receptive to having extra help.
Mm-hmm.
None of the hospitals chose to decline or drop out due to the only one choice: participate or not participate.
Okay. Great.
Shelly, hi, it's Bridget. I have a question. Do you think this is something they'll continue?
We'll see how, the results come out. There was very little money that was that did not go directly to the hospitals. In fact, it was such a small amount that they probably would not have been able to do anything on their own had the money been redistributed to all of the hospitals individually. So in this case, we'll see how the outcomes are. As I said, they all wanted to improve and learn more about quality improvement. We got a lot of positive feedback about the extra TA that was pushed out to them. So if you were to ask them, are you part of the Alaska Quality Improvement Network, they would be confused and they'd say, I don't think so. But this was a way of being able to give them the help that that they appreciated, even though they didn't get that extra money to do an individual effort with it.
So you don't think over time they'll appreciate the working sort of more collaboratively to get support versus smaller individual projects?
I think that they may choose to have more of this collaboration type of work. I have not had the chance to go back and really talk with them and get more comprehensive feedback about what we did to them this year.
Any other questions for Shelly on the Alaska model?
Looks like Oregon is typing.
Okay. Well, she asked if, have you heard if they have reached out to one another or been more collaborative in this work since pooling?
There have been some other collaborations that I have helped to facilitate. In one example, we had critical access hospitals that had the CPSI reporting system, and one hospital was having a lot of turnover and a lot of trouble extracting data out of their medical records. So what I did is, while I was facilitated during the project, having another hospital that had a CPSI system that was the same as theirs and was much farther along, I was able to get those two hospitals connected, and they were able to work together, and they were able to then mine data from the the electronic medical records of the hospital that was having problems. So what it is it's more like a hub and a spoke. I'm kind of the hub. I'm the one who gets the data coming in, data from the SHIP program, but also a lot of data from the FLEX program as to where people are having problems and struggling and stuff. So looking over what those problems are, then I try and facilitate and arrange for technical assistance to go out. So it definitely works more like a hub and spoke.
Great. Thank you, Shelly.
You're
Good.
welcome.
And Shelly's put up her email and phone number, so if you have additional questions on if you're thinking about that for the next cycle and want to look at her model, please contact her directly. And now we're going to move in to the next section of the webinar, Improving the SHIP Program. And on the, as I mentioned, the fiscal year 17 SHIP non-competing continuation progress report, Bridget Janine added some new questions, and Bethany's going to walk us through some of the responses, and then she and Bridget will tag team through the polling section.
Thanks, Sally. Hello, everyone. My name is Bethany Adams. I'm the Senior Program Manager for the SHIP program and the Small Rural Hospital Transition Project at the center. Thank you very much for joining us today. First, the Center of the Federal Office of Rural Health Policy, we're constantly seeking ways to improve SHIP program services for the hospitals and technical assistance to you, state coordinators. In addition, we want to know what resources are needed to support your hospitals. As you probably recall, state coordinators were asked to provide feedback and input on how to improve the SHIP program in the fiscal year 17 non-competing continuation narrative. From the responses, from the state responses, we collated a list of top suggested activities and commonly recommended improvements. So today, we'd like to build on your feedback from the NCC narrative and gather additional information from you to help us gain a better understanding of hospital needs and how we can improve services. Changing slides. So from the first question from the NCC, what SHIP activities are most important to your hospitals? The overwhelming responses for this question included quality reporting and improvement, HCAPS, ICD-10, HIT, equipment, and trainings. So we'd like to stop here for a moment and run a few polls and help us take a little deeper dive and gain a little more information from you about this. So Becky, would you please pull up the poll questions?
Sure. So we're now going to give everyone a few questions to answer through Adobe Connect to get your feedback. And I'm now going to pull up the first question, which should be appearing as a gray dialog box on your screen. Of your hospitals that selected HCAPS investments for SHIP, we'd like to know which type of investment is more important to them, to offset the cost of actually implementing HCAPS or to hold trainings and or projects related to improving HCAPS scores. So we're curious, is it actually the cost of implementing the survey that's most helpful to your hospitals, or is it the related trainings or projects? And of the responses that have come in so far, it looks like quite a bit are using SHIP funds to offset the cost of implementing HCAPS. We have a couple who put more priority on holding trainings or projects.
Looks like some are still coming in, Becky, but clearly looks like the majority is to offset the cost of actually implementing HCAPS. This is great information.
Yeah. And you know what? It looks like, well, we got one more here. Responses are slowing down here just a bit. I think I will actually move on to our next question, which is also related to HCAPS. So let me pull that one up here. And here, our second question, of those hospitals that have selected HCAPS investments for SHIP, have these quality investment resources led to higher HCAPS scores? So we're asking you to answer yes, no, or unsure. Yes, our hospital's HCAPS scores have improved. Unsure if our hospital's HCAPS scores have improved, or no, our hospital's HCAPS scores haven't improved or even fallen below previous results. And right now it looks like we're evenly split between yes and unsure. A couple more unsure now.
Seems to be.
Looks like responses are slowing down, but yes,
Yeah.
very close call. One more person answered unsure, then yes, but still quite a few yeses, and 0 have answered no, so that's a great sign.
Yep.
Great. Thanks, everyone, for your input on these. You're doing great so far. I actually have one more question that's related to HCAP, so I'm going to go ahead and pull that one up now. Here for our third question. So as compared to the current fiscal year, do you foresee HCAP's investments to be more or less important to your hospitals for fiscal year 2018? And we'd like to know whether you think HCAPs will become more important, HCAPs will become less important, or will HCAPs remain at around the same level of importance? And it looks like overwhelmingly here as we get started, it looks like HCAPs will remain around the same level of importance for your hospital. Great responses. We appreciate hearing this feedback from you because we can assume the answers, but we don't always know for sure, so it's great to get this feedback from you. Before we move on, I have one more question that I'd like to ask right now. I'm going to move on to the next question, which is about ICD-10. So similar to the last question about HCAPs, as compared to the current year, do you foresee ICD-10 investments to be more or less important to your hospitals for fiscal year 2018? Will ICD-10 become more important, less important, or around the same level of importance for next year? This is interesting. So of our results so far, it looks like they're almost split between ICD-10 becoming less important and remaining around the same level of importance. Okay, it looks like responses have been slowing down here. I'm actually going to turn things back over to Bethany to run through a little bit more information, then we're going to go back to a few more poll questions.
Yeah, that last question was very interesting. I would not have guessed that response, the ICD-10 remaining at the same level or a little less. So again, really great information to have some strong feedback and help us with some decision making moving forward with the future programs. So fantastic. So again, through the review, we were looking at, well, what's the most frequently mentioned activities. Oh, I forgot to change my slide. There we go. We also received quite a bit of information regarding the importance of population health management, care transitions, care coordinations, patient satisfaction measures beyond just the HCAP scores and just beyond the performing an assessment, maybe even moving more into the importance of patient and family engagement, which again is so important now to really keep those HCAP scores up, and of course then that ties into the care transition piece right above. And other frequently mentioned activities was infection control and of course marketing. And along with that information that we thought was very interesting, comments and suggestions. We also discovered there was maybe some misunderstanding of what's allowable or for the federal funding, how to utilize the funding. So of course, we received a couple technical assistance emails asking for clarification, so we thought we would share this now. So yes, as a reminder, you can utilize the funding to support telemedicine, revenue cycle management, systems performance training, software, hardware. However, you were not allowed to utilize the funding to support travel costs and hospital staff salaries. So that really does summarize then some of the key findings for the question regarding suggested activities. Becky, before we go to the next slide, I think we do have another poll question around this.
Yes, there's another poll question we'd like to ask you. Although, as Bethany mentioned, there are some things that are just a bit out of our control for this program. As we're looking at SHIP into the future and what that might look like, for this question, you could actually select more than one answer, and we'd like you to limit that to 3. So if you could select up to 3 responses to this question. And so we're asking, which of these activities listed below would be most beneficial to your hospitals and would demonstrate measurable outcomes? So we have here population health management, care transitions, care coordination, patient satisfaction measures other than HCAPs, ED caps, for example, antibiotic stewardship, hospital-acquired conditions, provider-based RHC support, or cybersecurity. Getting a lot of good responses come in.
Care transitions is definitely at the top somewhere. Population health management. Patient satisfaction and antibiotic stewardship is about even or close.
Same with provider-based RHC support.
Yep, those are really close. The care transitions and care coordinations definitely seems to be at the top with population health management following, and that makes sense. You need to help them with care transition, care coordination to position them for population health management. So step 1, step 2, that makes sense.
Great. Thank you, everyone, for filling that question out. We really appreciate your input. Looks like responses have slowed down a bit, so I'm going to go ahead and let Bethany move on to the next slide.
Thank you, Ms. Becky. So from the NCC responses for what program improvements or technical assistance would help SHIP better serve your hospitals, that question, the most frequently mentioned responses included less administrative burden, more specific investment options. I think this is where we need some clarifications. So the responses were more specific investment options, and then the other side was more flexible investment options, as well as hospital-focused TA, alignment with flex, and standard outcome measures, which all of these responses very important and well thought out. So we really appreciate everyone's responses in the NCC. So we'd like to again stop here, do another few polls, questions with you to have a little deeper dive and try to gain additional information and some clarification to help us with planning with the NCC, planning for the next round of SHIP. So Becky, you want to pull up the polling questions?
Great. Yes, I have a couple more questions for you, everyone here. I have to admit, this next question is my favorite. I would love to know what everyone thinks of this. So which of these two options would be more helpful to your state's SHIP program? Either more specific investment options that clearly define all that's allowable, or broader investment options that provide states with more flexibility. We heard a lot of both of these feedback options within the progress report, so we were curious to see if we post this on a webinar, what the response might look like. Looks like quite a few folks are selecting the second option, the broader investment options that provide states with more flexibility. So we do have a few who are opting for more specific options with better definitions.
This is an important question because it's a bit of a trade-off. So broader investment options, that when we provide that option to the states, you have to then have almost some understanding and work with us, or get some better understanding of, well then, how can the funding be utilized? More specific investment options, there's more clear definitions, but less opportunities to be a little more flexible. So it's a trade-off. But clearly, seems like broader investment options takes the day on this one. It's almost 90%, 87.1. So
just one thing with the broader investment options is that with that would come state coordinators would have to be able to better discern within the legislation of SHIP what would be allowable and unallowable for hospitals to pursue, so with regard to that legislation. So that's just a reminder that the current menu is one that's been vetted for appropriateness and overlap and linkage to the legislation. So anything that is broad, that is a broad category. Even within that, there may be some things that aren't allowable. So just a reminder for that one.
Great. Thanks, Bridget, for that. Excellent. Well, it looks like everyone has gone ahead and responded to that question, so I'm actually going to move on to our next poll. We had received some interest from states in receiving more hospital-focused technical assistance or resources. And so we were curious, how often do you as SHIP coordinators share the hospital web-based resources created by the center here with your SHIP hospitals? Is it something that you always do whenever you see something come out from us, you always pass it along? Is it something you usually do, sometimes, or seldom or never? We're just trying to get a sense of what your program looks like and what your relationship is with these resources and passing them along to the hospital. There's no wrong answer here. So far, it looks like no one has selected always. We do have quite a few sometimes, which is leading the pack, followed closely by seldom or never, and then about 5 usually responses so far. Great. These responses will be very helpful to us as we're thinking through where to focus our technical assistance and our time and resources in the future to support SHIP. So thank you for your thoughts on that. I have one more question that I would like everyone to answer, and I think it'll be a fairly easy one. We ask this often in other types of formats. We're just looking for a check-in here and see on either a formal or informal basis, are your state's hospitals currently engaged in a SHIP network, a SHIP consortium, something that allows your hospitals to collaborate using the SHIP program? It looks like so far we have 3 who have said yes, all of our hospitals are participating in a network or consortium. And then it's pretty evenly split between some hospitals are participating and none of our hospitals are participating.
Again, this is great information for us to think about what resources we can help create, deliver to you, to encourage your hospitals to think about how to pull their resources to be more efficient. Maybe it's providing examples that it doesn't have to be a formal network. It could be, as we say here, informal. It could be small work groups. Maybe it's multiple small work groups within your state, which is still more efficient, and that's allowable, and maybe even more beneficial to your hospitals. So we can further explore these questions and how we can give the right information to you to help encourage your hospitals to think about being more efficient with the funding and to ultimately provide them with better service. So this is very helpful. Almost 50% saying none of their hospitals, 40 saying some, and then kudos to the ones that 10% there.
Great. Well, that was my last question for the day. Thank you to everyone for participating. We really appreciate that feedback. As Bethany said, it really helps the center and FRHP really think about planning forward for the future.
And as we go forward with future TA calls, we'll try to include some of these polling questions and to get your feedback and to continue to address the questions so that we can help you, encourage your hospitals, and also provide you with the right resources that your hospitals are looking for.
This is Sally.
I think I'm going to turn it back to you then.
Okay. There were a few questions or comments in the chat box, so we could cover those in the last few minutes here. Judy from Minnesota State, it would be helpful to get copies of the legislation that defines what's eligible. And we can coordinate with Bridget. I was just looking to see, and then John asked about the, John Vermont asked about the SHIP menu and explanations, and the purchasing menu is on the SHIP website. So maybe, Becky, we could put that link in the chat box.
Yep, I will do that right now.
Okay, great. And yeah, suggestion to include in the grant guidance. Okay. Guidance on the advancement of SHIP funds. Okay. Good. And Becky's put in the link to the SHIP TA webinars. Okay.
Hey, thank you all for your questions. Nancy Joe, you had a question about advancing monies, SHIP monies. Can you clarify exactly when you mean to advance money and how you mean? If you could clarify your question, that'd be helpful.
Can you hear me?
Yeah, go ahead.
Okay. Well, we had a situation where for the past several years we had contracted with our state hospital association to distribute all of the SHIP funds, but our administration decided that that was advancing funds, federal dollars, and that we're not allowed to do that. And no matter how much we talked, and I think Benjamin White, I talked to you about this, I talked to Bridget Ware about this, but no one that could really put it very clearly in writing to us that it was okay to advance the SHIP dollars up to 12 months, which is the life of the grant year. And so instead, we had to do about 60 subawards to all of our critical access hospitals, and they have to draw down the money. So when I talk to people on the phone, it sounds like, oh yeah, you can do that, and you can do your money however, your SHIP awards however you want to do it. But when it really came down to, I need this in writing, and I need it very clearly in writing that we can advance funds up to 12 months, so that my administration says it's okay to do that.
But that really, again, because we're pretty benign about that, that is an indicator. We don't put it in writing, but it's an indicator that really it's up to at the state level to make that decision. And one thing I think would be helpful if any of your peers with many hospitals, many SHIP hospitals, if they've dealt with a similar situation, if you could hear from them how their state handles it, maybe you could share that with the folks that you work with.
I can tell you that if you don't put it in writing, it doesn't matter. If it's not in writing and it's not clearly stated, then it doesn't help us.
So could we say that there's no prohibition against?
Yeah, I mean, but the most we'll say is there's no prohibition on our part about it. That's a strong statement, but we're agnostic about it either way. It really is a state decision, and we leave it at the state making that decision as to how they distribute their funds.
The statement that I received had something about as long as, I don't have it in front of me, but as long as the appropriate guidance or I don't know what it was. But nowhere did anyone say, yes, you can advance those monies up to 12 months, and yes, it's okay to do that. And that was what I was asking for, was a clear statement like that so that we could go ahead and continue with the process that we had been using. And our administration said, no, you can't advance those funds. They're saying appropriate measures need to be in place, and those appropriate measures include not advancing funds more than 30 days. And so we're doing about 55 subawards now instead. So it's been a huge time commitment and suck on our part, changing that process over.
Hello?
Yep.
Yeah, this is BJ. This is Benjamin White. Just to give you some clarification on that is that HRSA does not determine what each state department, how you manage your budget. What we do is that we determine once we give you the grant, but then when you're distributing it to sub-award, if you distribute it to the individual hospitals, then that is, a handle within your State Department.
I'm
So
talking
just to give you a
about,
clear,
yeah, but I'm talking about the federal guidelines. I'm not talking about anything that's specific to SHIP. I'm talking about federal guidelines on how federal dollars can be administered. And that's in the Universal Circular that all federal grants have to follow. So I appreciate that you as SHIP folks don't care how we do that. But it's in the Universal Circular that you cannot advance funds for more than 30 days. And so when you say, yes, you can do that, and we don't care that you do that as long as you have the appropriate safeguards in place or whatever the verbiage was, then that reverts us back to that circular, and the circular says we can't do it. So I totally understand and appreciate that you guys are all about letting us do it how it works best for us. But what I'm saying is that we have people here that don't want to get us to get an audit finding. And if it says in the circular that we can't advance funds more than 30 days, and in order to bypass that, we have to have a very clear statement that says from our funders, yes, you can advance for up to 12 months. That's what we need, because we have a universal circular that says you can't do that. And without that clear statement, then it doesn't make any difference how much you say, yeah, you can do it however you want. So
Hello?
I'm just, I'm just sharing what happened
Yes,
in one state. This is what happened for us. We weren't able to do the process that we had been doing for years. I don't know if you can't do that. That's fine. I'm just throwing that out there to say this is how it impacted us.
well, this is VJ again. If you still you still have questions or you still need that answered, you send me another email. My email is bwhite@HRSA, and I will run down to find out what other avenues we could take. Because I remember we were back and forth with this before. If that helps.
Yeah, it's too late for me for this year because we've already had to do the subawards. But I've already told you what I can tell you. I have nothing else I can say to explain the situation any better than I can think of, other than I know, Ben, I did get several emails. You and I went back and forth, but the final email, when I even said, so from your email, can we advance? And you said, yes, you can, as long as you have the appropriate, and I wish I could remember exactly what you said, but you put in there at the end, as long as you have the appropriate measures in place or whatever. And so that was interpreted to mean that we're following the circular, and the circular says we can't advance more than 30 days. So it was just kind of frustrating on my part. And I don't know if there's anything else you can do about it because, again, it's what this Universal Circular says. And you're telling us that we can go and do something different than the Universal Circular says we have to do.
I see. If you want to address that again, you can send me an email. We can try to see if there's other avenues.
Okay. Thank you, Benjamin.
Sure.
Hey, sure. And as we noted, the webinar was recorded, so Becky will be sending out the recording and slides as well, and we will be posting information for webinar in the fall, and also we're updating the website resource page and streamlining the resources for the different purchasing options in SHIP, and we will send a